Welcome to the Dr. Frank and Steve podcast with your hosts, Dr. Frank Williams and Dr. Steve Snodgrass, MD, FACS, where we discuss a broad range of topics without limitations. Let's get to it. Here's Dr. Frank and Dr. Steve.
Hello, welcome. This is the Dr. Frank and Steve podcast. Today we're going to be covering physician burnout. I'm your host, Frank Williams, and this is my co-host, Dr. Steven Snodgrass, MD, FACS. So this is a subject that's, not real well known out there other than amongst the medical communities, but it is something that affects everyone, not just doctors, their staff, but and patients, but which is basically everybody at some time, from the time you're born to the sometime or at some point in which you die and pass on, you're going to be a patient. So we're going to cover what's going on and maybe some of the root causes of physician burnout and some things that can be done to kind of to help stem that if possible, and what we can do as Americans and as people around the globe to try and help curb this issue and this problem. So Steve, I'm going to let you start off since you are the physician.
All right. Well, thank you and welcome everybody. And as Frank said, this is a problem that basically, if you're a human, it affects you in some manner. I mean, it just does. And it's being defined as a long-term stress reaction that's characterized by depersonalization. It's kind of an official term for it, if you will. But it differs from depression because it primarily affects your professional life more than anything else. So, and it also involves people who are intimately associated with others in the workplace. So obviously that's going to be physicians.
Right.
But they also mentioned military, social workers, first responders, teachers, things. I mean, again, basically, if you're human, everybody's experienced it. But I think one of the things that was really starting to shine a light on it was obviously so many doctors being overwhelmed taking care of COVID patients. I think that's where it all kind of like really
hit its peak.
Hit it, yeah. And I think that was one of the things where everybody was focusing on. And just the tremendous workload. But one of the things too that characterizes just negative attitudes towards patients, and that would be a cynical type attitude or lack of sympathy or empathy and treating people like objects versus human beings, which, that obviously along the line of your work, that does happen occasionally. And emotionally exhausted, where you just lose enthusiasm for your work, is another key component to it. And then one that I think is really kind of central to it is like you get a feeling of decreased personal achievement, that you feel like you've been ineffective in your work, especially when you work so hard and then you have a bad result, the ultimate being a death. So, and we certainly saw that in COVID.
Yes.
When everybody was working as hard as they possibly could, and then there were a lot of people dying. And so I think that was one of the key elements of burnout at the time. And I know you've been talking to some of our, you got students who are physicians, and I know that you've been talking to them about it as well. And
absolutely. As a matter of fact, there's one that went from his private practice, which he then sold to a big conglomerate of clinics and clinicians, and he was seeing sometimes, especially during COVID, when they were allowed to see patients, said his peak reached about anywhere from 36 to 45 patients a day to squeeze in just to get them done. And so he has recently, which is my personal position, and with Steve's as well, moved out of state because he had 25 plus years and was an excellent doctor. But he went ahead and took a contract, which, I don't blame him for that. I would too, to where he is limited now under the military style hospital he's working at to where he only has to see anywhere from 6 to 10 patients a day. And he said that's where they cap him at, pretty much 10, no more than 12. And it allows them a lot more time to be personalized with the patients, to delve in and find things that maybe they have to rush through and not find, like they normally would during a thorough examination, and maybe ongoing attention given to those specific patients. So he seems to be a lot more de-stressed, seems to be happy and healthy, or as my partner used to say in law enforcement, he's fat and happy now. So he's kind of, not that he's not fat, because I'm sure he'll watch this podcast and catch it from me. So when we're doing a Zoom private lesson or something, but he just says it's a real thing, and you can see it, and you can see doctors stressing out. And a lot of that, as Steve said, and we'll go into that, about, a lot of it has to do with age. A lot of it has to do with specialties. In researching this and pulling the numbers down from the American Medical Association, which we've got links for if people need those, or I do rather, and the NIH, and many studies that have been done about who's at the biggest risk of, potential burnout. And emergency room doctors are like in the top right there. Then surgeons are right there also, only because, and I'm sure Steve's going to go over some of this, but we are going to be in such a shortage coming up over the next 10 years of just clinicians, physicians, which are MDs and DOs, along with surgeons. We're nowhere near at the pace we need to be to keep up with the demand that we're going to have during that point.
Yeah, and I think we are definitely going to have to focus more than ever. I feel that we need to have our primary concern is prevention rather than treatment of disease. And I know that's very difficult sometimes, especially with an aging population, because there's only so much you can prevent because of age and that sort of thing, because things are going to happen to you if you live long enough. I mean, it's just all there is to it. And but I feel like that you still see a lot of young patients who are on multiple medications. And I that's one of the reasons I went into surgery, is because there's a lot of different nuances to it that you have to learn, and it's obviously an invasive practice compared to an internist or something like that. But I look at them, and where I have the utmost respect for them is they have to look at all these different variables, and then the fact that people are taking medications by the box load instead of like a little paper sack full. It's like by the box load.
No, and to go along with that, my daughters and my wife and I, who can't stand drug commercials, by the way, and we don't watch that much TV, but when we do, there's always drug commercial. And we're one of only 2 countries that allow drug commercials. I think if you cut those drug commercials out, and they say, well, they do more good than harm. I don't know. I've never seen a statistic on that yet, but I would imagine some of the burnout, like you said, some of the stress from these doctors are, you see all these drug commercials, and people, whether you're a hypochondriac or not, they start telling you, ask your provider about this, ask your provider about that. Now all of a sudden your provider's got to play the bad guy or bad girl, depending if it's a male or female physician, which is only 2 genders I know, that are basically, because they have to tell you, yeah, but that's not really for your situation. And some people, and I've witnessed this personally with friends, they'll go to and relatives, unfortunately, they'll go to a doctor until they get what they want, basically. And that's just horrible, because like you said, Steve, you don't need to be pumping out 15 different medications because they want on something. So, well, I'll give them a mild dose that won't hurt them, kind of like a placebo effect. And I'm not saying doctors are going against their Hippocratic oath or anything. I'm just saying these people come in and rather than having to deal with that confrontation and that, with those patients, sometimes it might be better to say, well, a low dose would maybe, they could use this, but it won't interact with this or this. Like my father-in-law, again, as most of you know, I take care of a 95-year-old. He's going to be 96 shortly. Does well, just had his checkup recently and everything, his dental appointments, all that. And I'm his primary caregiver. And, God has blessed me to be able to do that, and I'm thankful for it. However, the man's only on a couple of medications. That's it. He's got a condition, and he's got for low blood pressure, and he does that, and basically, and he's about 6 feet tall, but he's not a very heavy guy. He's standard weight, but he's on a cholesterol pill, and other than that, an aspirin, that's about it. He takes a little sinus spray to help him with allergies, but if when they originally he had an incident a couple of years ago, which is why he's living with us, and they had him on about 7 different medications. He just let the doctor have it. He said, "Do I need this?" And of course, that's that generation,
Yeah.
Do I need this? Do I need that? Do I need this? Well, you could probably get along without it. He said, "I'm not taking it."
Yeah.
He said, "So, if something happens, I won't know it anyway."
That's true. And it really is quite remarkable that, a physician, like when you open your door and like all of a sudden it's just like 36, 40 patients. I mean, to have that to deal with and their families and that sort of thing. And you try to be as thorough as you possibly can. But, this whole thing, it affects morale, healthcare costs, quality of care, everything, every aspect of it is affected. And one of the things too that they keep talking about is just this increased administrative responsibility.
Mm-hmm.
And for me, I retired some years ago from the active practice of surgery, and I thought it was bad then. I thought it was getting worse then, but now it's much worse. And you would get phone calls. I think we've talked about it before, but I would get phone calls from insurance companies, and I had a patient that had 12 rib fractures, cardiac contusion. He was like an 88-year-old guy in intensive care unit and on a ventilator. And I get a phone call from the insurance company just saying well, we've reviewed this case and feel like he doesn't need to be in the hospital. So, it's just well,
Would you come and give him a ride yourself or one of your representatives?
I won't tell you what I said, but anyway, it was I just thought it was remarkable, who is reviewing these kinds of medical records to the point where they actually notify the surgeon that, hey, we don't feel like he should even be in the hospital. It was like, you think I've got him on the ventilator just for the fun of it? It's just amazing. And one of the things that I saw during some of my research was, if you look at it's Texas Children's Pediatrics, and they were just talking about the administrative headaches involved in that, and then how you have physician portals and that sort of thing where people ask questions about their care and all that sort of thing. They had 300,000 emails in their inbox. They didn't tell what time period that was, but they opened their email inbox and there's 300,000 emails. So they said we are trying to use artificial intelligence, to try to help us get through all this, because the physicians, they said each of those emails will be read by a physician, but I think if they're using AI to triage it and to say well, this is the most critical, this is this can wait a while, but can you imagine just that kind of volume and all of a sudden that there's your day and
exactly.
You got 300,000 emails faced.
Yeah, with all the new procedures that's come out over the last probably 10 years or so, maybe a little bit before that, I want to say maybe, 12 to 16 years. There's been a lot of changes as far as reporting, what's got to go in, it doesn't matter if you see an eye doctor or a dentist, everything that they do has got to cross-track into, things like the Affordable Care Act and the paperwork and everything. So that's what my eye doctor and my dentist said, all these things have got to track across different areas. So it just exacerbates the problem of, you got to get all that entered, you got to do all that, you got to make sure. So physicians, spend hours and hours, like you said, going through those charting and doing all this stuff. And so, which cuts back their time from being able to see patients, but yet they can't cut it back that much, so they've got to be able to see it. So that's where a lot of that critical burnout, as a matter of fact, as far as males versus females. Remember, I said there's only two genders, so don't be yelling at me because that's the way the study was done. But that's what I believe. 63% of female physicians feel the strain of burnout versus close to 50% of male physicians. So there is a differential there, even though that's still a high number. And when you were saying that cost, they're saying that burnout, physician burnout, because of that, is costing organizations millions a year per organization, and it's close to $5 billion a year from just a rough estimate on the loss because of the physician's burnout.
Yeah, I mean, it affects every aspect of practice, and then it bleeds over into your personal life. And there was a study that was published in the Mayo Clinic publication, and it said that physicians displayed almost double the rate of emotional exhaustion compared to the general workforce. So I mean, you can see it in the studies. And they also had a significantly lower satisfaction of work-life balance, almost 36% versus 63% of the general population, if you will. So it's just like, I keep going back to the Rolling Stones, they just can't get no satisfaction. So,
Well, you never know what you're going to walk into day to day. I mean, why doctors pretty much, I'm sure, see a lot of the same things over and over and over again. It can wear on you. I know when I was a police officer, I'd come on shift sometimes. There might be 15 calls waiting on you, and so and then it would be prioritized. Somebody broke in somebody's shed, somebody's cat, was stuck in a tree. Some guy had beat his girlfriend around and took off, to head out of state or whatever. So all those things had to be prioritized. And then plus what was coming through the dispatch at the same time when you clocked in or checked in for your shift. So there were a lot of days where you would just come on shift immediately. It was go all the way through, and you didn't get the finish a lot of it. So the minor things, unfortunately, somebody might have had to wait till the next day or day after to get like a theft report taken, or they got to the point eventually where they would do some of it over the phone, which was a blessing for the officers. But you don't know what you're going to face when you come in, and it's just like you said, when those 300,000 emails, to a cop or somebody, a first responder, when you've got it makes your shift go by fast, but you are humping there quite a bit, and so that builds a big stress level on even first responders, let alone these poor physicians. You come in and you've got all these caseloads, and you don't know what you're going to run into, and you don't know who you're going to run into, because not everybody, and I know we've discussed this about doing a podcast on workplace violence, but I've seen some aggression when I've taken my file off to the doctor or other people, somebody screaming at the top of their lungs at the poor receptionist because they felt they didn't get the treatment that they needed to get, or the treatment wasn't done in the way they were done, or it's just somebody with a mental health condition,
Oh yeah, and it's, one of the things that when I was reading about it, it kind of brought me back to when I was a resident, because at the time it was like the scrub sink is almost like the water cooler. You're just kind of like, that's where you have some discussions, the brief discussions and everything, but you kind of cover a lot of life topics in a quick period of time. And I was working with this older doctor. And one of the big problems on all this is it's called physician personality. And it's like you're in the work mode all the time. So I'm going to work now, and then I'm going to enjoy my life when I retire. And there's a lot of that goes on. And this one doctor, as I said, he was probably about 2 years away from retirement, and I'm like, a fourth year resident and everything. So I mean, I'm like, I'm guns a-blazing, if you will. And he said, like, let me tell you, don't think that, this it's all going to get all better once you get out and all that sort of thing. He goes, you won't believe this, but this residency period, some of the best times in your life. And he said, so, don't think it's going to be all wine and roses when you get out. And so if you want to, you got to have the ability to enjoy life right now, because you don't know what tomorrow brings. And it's so true. It's like especially for surgeons, I think, is like you're pretty much in constant work mode. And then for you to get off and then try to bring that elevator down, if you will, even if you are successful in doing that, by the time you do, it's time to go back. So it's just non-ending. And it's also, they just said, like, it's equivalent of always being in survival mode.
Right.
And I think there's a lot to that. I mean, you can relate to it, I can relate to it. And so it's just like you're just trying to get through. And as I told you one time that I was on call for an extended period of time and just looked at the hallway going into surgery, and the gurneys were just lined up as far as you could see, as if people were gonna, the ORs were running just full blast for days. And you look at that workload and just go like, well, this is gonna be quite something here. And you never can quite ever come down. You're just constantly
constantly up. Like I told you that time, I ended up working almost 22 hours straight because of a blizzard, until the sheriff himself come over and found out 3 of us had been working, nonstop for almost 22 hours. And he apologized, which wasn't his fault. It just happened to be what it was. If I could get out, if I could get around, other than some of our specialty vehicles. And the sheriff said, are you able to make it home? I said, yes, sir. Because I had a truck with chains and all that, which are a no-no, supposedly. I made it home. But, like you said, you're just so jacked up on adrenaline, being up for, a 24-hour period, and sometimes longer people are, you just can't turn that off automatically, which is a big thing. So I know what you're talking about. And I couldn't imagine, not comparing it to it, I couldn't imagine walking in, see a bunch of gurneys and all that stuff. And like I said, again, you're dealing with patients but again, you're dealing with not just patients who are in need, and you have empathy and sympathy, but you also have some that have mental health issues and everything else. And, you got aggravating patients who are hypochondriacs. You can't be like Eddie Murphy and just say, have a Coke and a smile and be quiet. I'll say it politely. I'm sure there's a lot of physicians that would like to say that, but I was reading some interesting facts and printed off that, between now and what is, I think it's 2036, but that's about close to 11 years, a little over away. There's going to be a shortage for surgeons. I mean, that's going to run because of the way that we're losing ground on physicians. Even though the physician burnout rate has come down since 2021, since COVID, it's still right there at about 50%, and it was at its peak. But that's a lot because the estimation is somewhere between, the shortfall is going to be between about 38,000 and 124,000 physicians overall. And then with surgeons, there's a great number there that it's going to fall somewhere between about 16 to 35,000 surgeons are going to be needed, and there's going to be a shortfall. They're not going to be available. And that's why I don't want to sound hard, but I keep saying we need to have really good policies that don't burn out our first responders, our resources. And I have agape love for everybody, being a Southern Baptist, but I will tell you that when you allow illegal immigration to the point where it's 8 to 12 million people coming across, and I don't claim either political party, I am telling you that that's the equivalent. Again, I'll say this, and I've said it probably on 2 videos so far, our podcast. That's the equivalent, supposedly, of about 36 states. You are not, within a few years period, or 3 or 4 years period, you are not replacing the amount of resources and personnel that would take to fill that 36 states worth of entities and organizations and teachers, doctors. The strain on the system is just too great. And I think over a period of time, we're going to see these numbers, if something's not done, we're going to see these numbers go drastically higher instead of lowering. Just because of it. Do you understand what I'm saying?
Oh, yeah.
Because you can't say, oh, we got enough new people in. over the border plus a few million gotaways that equal 36 states. And that's the first thing that came to my mind. How many cops are you going to need to handle that many people? How many doctors? How many attorneys? How many bus drivers? How many people work at the cafeterias? How many people work at the grocery stores? To take care of all this. And so, I mean, that's putting a strain. It's like adopting 36 new states overnight, just about.
And the thing too is when you're in pre-med and med school, and then you're in your residency and that sort of thing, you feel like you're pretty much invincible,
Mm-hmm.
and like anybody that's young, but you hear all these things, people that are older in the profession, and they try to relay what it's really like to be a physician, especially in surgery. Mm-hmm. and they tell you all these things, and you really just kind of like, yeah, I get it. And then you don't think twice about it because you're 30 years old. And right. And then, like, after a while of just basically you're just exhausted. You really are. You're exhausted. And I was exhausted when I got that phone call from that insurance company telling me that my patient really shouldn't even be in the hospital. And so the exhaustion plays a role in your response.
And yeah, I'll bet. And one of the things I keep reading over and over again, that it takes about 10 hours additional a week because of all the newer and the regulations for those electronic health records. And that's not something that staff does. That's something that, as a physician, you guys had to do and still have to do to this day. So there's a lot of that. And while physician burnout is a critical area to me, because it's an aging population, and which is some of the stressing factors on the marketplace itself for physicians and surgeons and specialists. Because I think the average, I don't know if you have that there or not, but the average is, there's a great deal of them that are in their mid 50s to mid 60s. Yeah. And so there's a lot of surgeons and experts that are starting to age out that we have not replaced. And that's why we're going to fall into such a shortfall for this area.
And I always said to myself, like, I don't want to be one of those surgeons that is shaking at the operating table. I don't know when to get out. I mean, I didn't have to make that decision because glaucoma made it for me. But anyway, it's like hanging on too long is something that physicians, especially surgeons, are not going to be able to do that, because the workload is going to be too great. And, by the time you hit a certain age, you're just not going to be able to carry that workload like you once did. And one of the things too that I thought was really interesting is, and it's very true, it's one of the things that make you a great doctor are the things that burn you out the most. Mm-hmm. So it's like you've got this exaggerated sense of responsibility, but then again, you really do have an exaggerated sense of responsibility, because it's somebody's life that you're taking care of, and your dedication and your commitment. I mean, you just give it your all. I always tell my patients, like, no matter what you have, whether it's a mole or an abdominal aortic aneurysm, well, I'm going to give you everything I got every time. And I really did. I can honestly say that I gave everybody everything I had during every surgery, because they deserve that. And so there's a lot of that goes on. And I feel like what you were talking about, to your point about how many now these organizations like hospital chains and that sort of thing have physician employees, and so every time that you lose physicians, I mean, there's costs like recruitment, sign-on bonuses, lost billing, replacement costs range anywhere from $500,000 to $1 million per doctor. And so, and there's lower productivity, because if you're burned out, you're not going to schedule as many elective surgeries. You're not going to see as many patients in the office. So it's going to decrease your overall productivity, and the patient care revenue is going to go down, and there's a lot of intangible costs with increased medical errors and higher malpractice risk and reduced patient satisfaction, as well as damaged reputations for the entire organization. I've seen that, like, there'll be like a hospital chain, and there'll be a doctor that's performed poorly, and they are reflected in that organization. I mean, they're known as, oh, well, he's that doctor that.
That's happened around here, as you know. There's a medical facility that has like a 1 or 1.5 star rating, and my daughters asked me. They said, "That's not where Mom's going when she has her cancer surgery." I said, "No, we're going to the Vanderbilt Medical Center down there because they're probably, in my opinion and my wife's, the best in the world. Thank God they were there."
Mm-hmm.
But as I told the girls, and I use this thing sometimes, I said, "Well, girls, it's a 1 star rating, but let's put it this way. There's no such thing as a no star rating." So you're pretty much at the bottom.
And one of the things that, we've all talked about this, and it's the fact that physicians' pay has a 29% drop in Medicare payments since 2001. So I mean, it doesn't even keep up with inflation, and so it's a terrible thing, because basically there's that mindset of like, the harder I work and the smarter I work, the more I get paid.
Mm-hmm.
And so you're doing all this, and then you watch your pay go down.
Yeah, because costs don't go down.
No, I mean, and it's, for me, one of the things that was a key level of frustration for me was that I never ever had a malpractice lawsuit against me. Never. And I never had a formal complaint against me, maybe a few informal, but that's neither here or there. But the whole point is that I never got sued. I never had anybody write me up or turn me in for some sort of bad behavior or bad outcome or anything like that. But my malpractice insurance rates just kept going up every year. And I would just say to the provider, I just say, what is the deal? Because like, I have never been sued, and you just keep raising my malpractice rates. I just said, I feel like I'm working, a lot of my job is just to pay you, it's like, well, they don't really care.
And we've talked about that, where I have a student I trained and for years, and is a super nice guy in another state as an OBGYN. And it got to the point where he was paying about half of what his intake was because of that specialty out in malpractice insurance. And at the point he just about gave up, another large organization came in, a hospital organization, and bought his practice. He said, other than that, I would have just quit doctoring. I went in something, he said, there's no way. He said, I just, like you said, I feel like I'm working, and if I see 2 patients, I know one of the patients is free to me because everything's going to the other, to the malpractice insurance. And he said, for him, luckily, they had a large group coverage through the hospital association that bought him out. And he said, do I make a lot less gross? Yes, I do. But he said the stress and the overall money that he made being under salary and everything taken care of, he said, it was getting to the point, he said, I just couldn't even function half the time. He would just be so stressed out over everything.
And one of the things too, that one of the reasons that I went into medicine and in surgery in particular is because I wanted that autonomy. I wanted to be, I didn't want to have to answer to anybody or anything like that, even though you do, but you may not know that you do. But, I really had like no direct boss or anything like that. And so that autonomy was very meaningful to me. And so like, if you get bought out by what you're talking about, it's like, it's good and it's bad, because it's gonna take care of some problems, but then you are gonna lose some autonomy.
And you're gonna have a whole set of, and like he found out a few years later, he said some of the rules and some of the procedures and things that they put out, He said, they're hard to deal with, but he said, I made my bed, I'm going to lie in it.
Yeah. And this is extremely painful for me to say, but I think now more than ever, I think that finance is starting to play a role into decision making.
Dictates those decisions. Yeah.
And so, I can tell you, without question, not one time did I ever consider what I might get paid for something. What if a patient needed surgery, I operated on that patient. If that patient, for whatever reason, did not need surgery, and a lot of times for me, just about everybody that saw me needed surgery, they weren't there, but sometimes, like, for a hernia operation or something like that, it's like you would have the discussion of, let's like, how does it affect your lifestyle? And let's look at your overall general health. Like if it's an older person and they, by the way, this is one of those little things that you can always take away, but a big hernia is safer than a little hernia, because a big hernia, most likely, it's like, the intestines are hanging out, all that sort of thing. And it's just like, more than likely, you're not going to get into a surgical emergency. But if you got a little hernia, and, those are the kinds that can trap a piece of bowel and get you in, to a small bowel obstruction or a bowel infarction, more likely to lead to an emergency surgery. And my whole point of that is that comes in decision-making process. Like if you had like an 80-some-odd-year-old who's got like congestive heart failure, stroke, diabetes, smokes, drinks, all that sort of thing, and he comes in with this massive hernia, and he says like, well, do I need to get this fixed? And I was like, well, more than likely you're going to live with it, you're going to die with it. But if I operate on you, you've got so many risks that kind of prohibit this, unless it were different circumstances. Like if it were a small hernia and you had come into the hospital with multiple episodes of a small bowel obstruction because of the hernia, and they reduced it, that means they got the hernia taken care of non-operatively. That's one thing. That's going to get you a ticket to the operating room a lot quicker. But I just never based any kind of operative decision whatsoever on money, not one time. And I think that is coming into play, and I hate to say that, but I think it is. And so I think that goes back to one of those things about how we must be our own advocate. We harp on that a lot, but we do it for a reason.
Yep.
But I did find in the literature the highest percentage of burnout in the physician specialty. And it varies, but I thought this was interesting, but they took the top 6 specialties, and hospital is ranked number 6, and that's basically a physician that is committed to take care of inpatients. And a lot of times they'll have like an academic or teaching role or administrative role in addition to their medical role. And then pediatrics was 5th, family medicine next, OBGYN, internal medicine, and then emergency room medicine was number 1.
Yeah, 65. Yeah, I got those statistics I pulled off because I was like, wow, that's the chances of becoming or for burnout. I said, man, that's incredible when the majority of them are all well over 50%. And the ER doctors are over 60%, along with like internal medicine people, which is what that friend, student, and former doctor of ours did or does rather, and amazing. But so how can we to maybe help alleviate, or what are some ways that you think of? I have some ways, I think, but some ways that may help physicians with burnout.
Well, before I get into that, I want to say a couple things. One is like, for me, this is me personally. If I went into pediatrics, if I went into that, I would probably last, I'm going to say an hour or two. I don't know. But it's like, here's a great one that I can't begin to tell you how many times I've heard this. Being a surgeon, you had to take pediatrics in med school. You had to rotate through it, and then I had to rotate through pediatric surgery as a surgery resident. And I can't begin to tell you how many times I've heard this, where the parents would say to the child, "Because you're so bad, that doctor's going to give you a shot."
Yeah.
And so
That poor kid's already coming in with an attitude.
yeah, so the kid just hates you automatically. So, of course, there's part of the white coat syndrome they're learning at age 1.
Yes, yeah, that's true.
So it's like, that's ingrained from early on, it's like, but I can't begin to tell you how many times I would say, I've heard that. And I've gotten to the point where I would like prophylactically say to the parents, whatever you do, don't tell your child that because they're bad, I'm going to give them a shot. Please don't do that. And they'd say like, well, yeah, we use that a lot. It works.
Yeah.
Like, sure it does. But when I mentioned depression earlier, and I thought these were, and I wanted to bring this up before we address your question, the final part of it of what can we do to help. But there's a big overlap of depression versus burnout, and we went over the difference. But depression includes not only your occupational experiences, but also adverse childhood experiences and the thing that's kind of called your life. So not just work. But I found it interesting that the doctors with the highest level of depression were urologists. I'm like, I don't know. I mean, you kind of know what you're getting into.
I would think.
But it is what it is. Emergency room medicine next, family medicine, OBGYN, internal medicine, physical medicine and rehab, radiology, pediatric psychiatry, dermatology. And the lowest level of depression was found in ophthalmologists. And this is just kind of an FYI kind of thing for whatever it's worth. But there you go.
Maybe they can see the issues better.
Maybe so. Yes, it's in their rearview mirror or things. I don't know. But ways to address it. But ways to address it, I think one of the big ones is that I had read about was that physicians never have felt more lonely and isolated. And there's a lot of colleague interaction that used to take place but doesn't take place as much as it used to. So I guess you need somebody to cry in your beer with you.
Like interpersonal relationships.
Along those lines. And then a lot of times too, as a physician, when you're talking to a person who is not a physician, they can't relate to it unless they've had some sort of similar thing. Like for the two of us, I mean, I was in surgery, you're in the military and law enforcement. And so it's like, those two to me, they overlap a lot. And so we never run out of things to say.
Right.
And because like, you understand death and dying, I understand death and dying as part of your job. Whereas a lot of people think like, a death actually occurs. Like, yeah, they do. And so I think a lot of it is just trying to, as you say, just interpersonal relationships that you have to establish and keep. And the other thing too, really, there's a lot of doctors that disagree with the AMA, and I mean, and again, I've had policies they've had I don't agree with, but overall, I think they do a phenomenal job of watching out for doctors in political things they do, as well as some of these things they've got called like a Step Forward program that specifically addresses physician burnout. So they do basically kind of a diagnosis, or if you will, or break down each segment of a physician's practice, their life, their specialty, and that sort of thing, and they gear treatment towards what they're going through. And so I guess the whole point is is that the AMA has an organized system of trying to help physicians overcome burnout.
And that's good.
Yeah, and so that's all really good. And they said coaching by professionally trained peers. So I don't know if that means like psychologists, psychiatrists, or whatever. Again, I personally would never hire a life coach because, I'm pretty much.
Just have a mother-in-law.
There you go.
My late mother-in-law was a great life coach.
So yeah, and I'm just like, I don't really need somebody to tell me how to react or what to do or anything like that. I've kind of been there, done that now. So that's not gonna.
And some of the research, you have the standard answers that people give, make sure that even as physicians, they have a healthy lifestyle, like healthy eating habits, they work out, don't smoke or any type of substance abuse. Make sure that they get involved in some type of hobby. Make sure they're taking either vacations or mini vacations when they're starting to feel that way. Counseling, as you just mentioned, whether it be mental health, secular counseling, interpersonal relationship counseling, like make a group of guys or join a group of guys, so you can go out and whatever. I don't care if you have a Coke, Sprite, beer, whatever it is, and where you can share, like kind stories, so you can kind of like vent and be accountable to each other. You have Christian counseling, you have faith and religion. Sometimes it's good for them to get more deeply, into their religion and religious studies. And a big one also is art therapy, and we've talked about it because we do a lot of podcasts on there and speak about it because we're involved in it heavily. But as Steve has said before, and I've said, you may have never picked up a brush or, sculpted or, done clay or quilted or whatever it would be, building something outside of outside of your normal, medical practice, but finding a way to relieve yourself and get into that, whether it be music, poetry, whatever, can be a great stress reliever for a lot of people.
That was next on my list to bring up, and Frank and I don't go over this with each other because we like to kind of have the freshness of it.
Yeah.
But art therapy was the last thing I was going to bring up. But one thing I do want to say, a life coach, it might be really appropriate for a lot of people, but for me, it would not be. I'm just way too cynical for that.
Imagine that.
I'm just way too cynical. And I was talking to my brother one time, and he just said, well, have you ever been to a psychiatrist? And I just said, no, I've never been. He goes, well, I just look at what you've done in your life and like what your job entails and all that sort of thing. I would think like sometimes you just need to kind of talk it out and all that sort of thing. And I just said like, no, if I went to a psychiatrist, they'd probably be pushing that button underneath the desk, just like, come get him, just come get him.
And just for point of reference and transparency, I've had multiple psychiatric evaluations because of work incidents, for shootings and different things I was involved in. And I will tell you happily, I passed every one of them. And that's either a good thing or I'm just that abnormal that,
Yeah.
So,
and they had there was one day I remember specifically is that I had a very elderly, frail, horrible surgical candidate for a patient that was taken to the operating room emergently. No choice. There's absolutely no choice. And it was like, and I told the family, I said, the chances of coming through surgery on something like this, as sick as they are with all of their underlying health issues plus their age, I said the chances of them surviving this operation are almost nil. But I guarantee you one thing: if you don't operate, it's 100% they will die. There's no question about that. So I took the patient to the operating room and was doing the procedure, and then about midway through or something like that, massive heart attack. Code the patient dies on the table. and I still have like 3 more surgeries to do. And so all of a sudden it's like I'm going back from, of dictating what happened and for medical records. And then I'm just on my way back to the lounge just to kind of like put my feet up for the next case. And they just said like, well, we have to cancel the rest of your cases for the day. That's hospital policy. I just said like, well, no, I'm not. And I just said, I don't know what policy that is or what. They said like, well, it's kind of like it's the hospital policy, and it's just kind of like part of the normal human experience kind of thing. It's just like you don't need to be back in the operating room after you just experienced a patient dying on the operating table. I just said like, well, if I don't do it today, I'll have to do it tomorrow, and tomorrow may be worse than today. So, I'm just going to go on. Plus, I was chief of surgery, so it's like, what are you going to do to stop me? Really?
Yeah, exactly.
It's just like, I appreciate your concern, and if I felt like in any way that what happened to that patient would have anything to do with this patient, I wouldn't do it. Right. Because I look at patient safety and all that patient outcomes is, that's what we got to do. But I just said, no, I'm just not going to do that. So I'm just going to go on. And so there you go.
And we're kind of alike in the mentality there because, as you know, and some of the guys here, I've let them read some of my old reports, being involved in a lethal incident before, it happened more than once. You'd have to see a counselor, psychiatrist, so they usually would have you off on light duty or off period if you were stressed out for up to 30 days or longer till they could evaluate everything. And I just remember seeing this one counselor, doctor, and my partner, who was an airborne ranger, and dropped into Panama and all that. He was a pretty seasoned, we had a similar background, and I just remember going up there, and it was a bad situation for the people involved, and I was involved in some others, but a couple of the guys had to end up retiring for stress. They just couldn't even look at their uniforms. And so being as abnormal as Steve is, they're like, hey, you got to go up and see them. We're going to pull you from duty until you get cleared. We'll make arrangements for overtime and all this. And I was a union president, so I'm like, well, I really don't know. And they're like, no, it's policy, which I understand, and it's a good thing to have. So you're not making sure you don't have weapons in your house, whatever, if you're really stressed out, because they don't want you to hurt yourself or a family member. But I can remember going up there, and this is about the 3rd time I'd seen this same guy, and my partner was out waiting because his was next, and it's supposed to be like a 2-hour evaluation and all that. And they ask you standard little questions, and then when I walk in, this guy looks at me, he goes, oh, Officer Williams, you're back again? I said, yes. He said, okay, I've got everything here. And he says, is there anything that's stressing you over this? And he starts asking me, and I said, well, I just can't sleep at night. I'm not able to eat. I said, I just think if I could get 30 days off to clear my head, I'd be good. After about 15 minutes, he's looking down. He said, okay, I'm going to go ahead and clear you back to duty tomorrow. He said, send in the other guy. And I said, well, that's Officer, or Deputy Reeser. And he just kind of had a look on his face. And so we were supposed to be up there almost all day, and we ended up, Reeser was in there about a half hour because he was talking about one of his exes. And so we went to lunch after that, and we no more than got to lunch. And our duty sergeant and stuff called and said, hey guys, I know you've already been up there today, but I need you guys in here tomorrow at your regular shift. Yeah. I said, well, how many people that are involved in this? He said, you're the only 2 that got cleared. But everybody's built differently, and I'm not taking anything away because I think counselors, psychologists, psychiatrists have a place and are wonderful. I trained several, some seasoned, some newer, and without them, there'd be a lot of people out there that would be in a lot of trouble. And they get burned out too, because, I just tell them, if you have no one else to talk to, use me as a venting post while we're doing our lessons or, doing our sessions or classes. So, my thing is everybody's built differently. My kids may look back one day, or grandkids, and say, Papa was a little eccentric.
There you go. Yeah. But I think a good thing to say, like to begin that conversation, would just be like, the only reason I'm here is because I'm such a great shot.
Yeah.
Make that argument.
Yeah.
It's like, hey, you really can't argue against that, can you?
No, other than pulling your weapon and maybe getting a battery of test done on you or something. Well, I think with that little joke, and that little analysis.
I'm just playing psychiatrist
Yeah,
here,
yeah. Please don't.
Hey, he's here because he's a good shot.
Yeah.
What can I say?
That could be. I mean, that truly could be. Everybody has the regulations they got to follow, and you got to be cleared somehow. But we want to thank you guys for being here. We look forward to the next podcast. And again, if you have any questions, just please click the like and subscribe button, or you can get through us through our contact information there. We look forward to seeing you the next time. Thank you.
Thanks so much.
Thanks for listening to the Dr. Frank and Steve podcast. If you enjoyed this podcast, please hit follow or subscribe on the link provided so you can stay up to date on new episodes. Until next time, stay healthy and stay safe.